I just wanted to thank everyone for the support. This has partially been previously funded through the first iteration, which was to make a tool to identify vulnerable patients. And this is a kind of an adjustment for where we want to take this in an additional direction, and that's to forecast our ICU needs and hospital bed needs. So one of the challenges right now, and this is an update from yesterday. And this is our census amongst the UCs on a per hospital basis. UCI actually has the highest count. The UC San Diego has 2 sites, UCLA has 3 sites, but on a single hospital basis, UCI has a pretty high COVID positive patients. Of those 36 patients, 16 are currently in the ICU, which actually represents about 30% of our ICU capacity. So the challenge is that hospital resources have to be balanced with other critical groups because we don't only have COVID patients, we have stroke patients, trauma patients, and post-surgical patients. For example, there is currently a backlog of elective surgeries that may require ICU care in the immediate postoperative state. Also, our oncology volume is expected to increase as screening resumes. Across the country, we know that oncology screening dropped to almost 70% in the months of March through May. And compounding all of this to add insult to injury is that COVID-19 patients tend to require much lengthier hospital stays and ICU stays. Within our own cohort, some of our ICU patients have 30-day ICU stays and beyond. And so these are all things that we have to balance as we try to prepare and allocate medical resources. So currently there have been some surge calculators out, but most of these rely on population statistics and provide an estimate or ideas for containment strategies for hospital needs. And while these do provide some information, these calculators really don't account for who's already in the hospital. These tools also aren't looking at patient level data. They tend to only be looking at what is the overall infectivity of the area. So the tool that we had previously developed incorporates demographic information, age, gender, the number of comorbidities and the type of comorbidities, lab values, physical exam values, and I'm going to show you what we've kind of built before. But what we really want to do is, can we predict when patients will discharge from the floors? Can we predict when patients will discharge from the ICUs? And can we also predict when patients will be extubated from if they're already intubated? And the idea is to help better plan for our resources. This is a tool that was developed from the first version of the funding. Thank you for everyone who helped support this. And this is live now. It's already being used clinically. I was just scanning yesterday, and here's just an example of a patient. And you can see now this is a 49-year-old female. This was her initial ER assessment. You can see that she had a 69% score. So this is someone in the floors using our tool. And then this patient was transferred to the ICU 2 days later. This is another patient. This is a 39-year-old. Also, you can see that there's a high probability of requiring ICU care, was admitted for higher monitoring initially, and subsequently did go to the ICU a day later. And so this is what we've been able to provide at UCI Health, is that this early alert and this early warning for our clinical teams. And so just kind of highlighting that. And one of the things that we've observed as we kind of QA our own data sheet is that we can actually look at the trends in the vulnerability scoring system, and there are some kind of characteristic trends. This is like for our ICU patients as an aggregate. We do see that right before they go to the ICU, they tend to spike. They tend to peak out during the ICU course, and then the scores, as the patient's inflammatory markers improve, we do see that the scores generally do come down. And so the innovation about this is that, as far as I know, this will be the first surge calculator that tries to leverage temporal data. It's also the first one that I know of that integrates also demographic data. We're now, Dr. Bernadette Boden-Abella is helping us integrate some of the socioeconomic and ethnic data. And then with Peter Chang, he's been really spearheading all of the algorithm development. He's kind of set this up so that as we input more and more patients daily, this model will continually update itself. Just for where we stand now in total patient counts, we are at about 510 patients, which is about 25% of all UC patients. And this has resulted in a pretty well curated data set. This was the original study team, which has been expanded to also include folks from UC Health. And so we have Ms. Susanna Rusted, and she's the Executive Director of Hospital Operations, and Eamon Offman, who's the Director for Patient Flow. And we're trying to find ways we've already integrated this tool for the clinicians to use, and now we're trying to integrate this at the administrative level so that they can kind of plan out what resources they need and so forth. Alpesh Amin has also been helping us to try to integrate this into Epic. Right now, clinicians have to go to the website, enter information, and so Amin's trying to help us to see, can we have this populate automatically? And so this is very exciting for us. In terms of what we're doing now, we're going to do another big update this weekend. We have about maybe, as I said, a little over 500 patients, and Peter's going to be trying to do some more sophisticated machine learning approaches. We are currently submitting for 2 grants at the end of this month. For submitting for 1 R21, using this kind of more of an ambulatory and the ICU setting, and we're also submitting 1 for the Moore Foundation. And so with that, I think if there are any questions.
Well, I can get it started with a question. This, not to put you on the spot, but what fraction or what number of patients would likely have been missed based on kind of standard practice without the VSS scoring system?
We are starting to look at that as we go retrospectively. I know we just started doing that analysis this week, and I've already seen a couple that they actually came to our ER, were discharged, came back like a couple days later, and then went to the ICU. We actually have a few patients like that. There was one patient in particular that came to mind. This is actually a patient who went to, I think it was Sutter, and then she had presented there. She was also discharged and represented, and then she ended up going to ICU and it was transferred here to our ICU. When we look back at her scores, she, on her initial labs, she was already at a high-risk patient. And so these are the kind of things that, we want to really avoid. And that's the basis for the Moore Foundation, is to kind of, I don't know if I would classify as a diagnostic error, but to kind of prevent, inadvertent discharges that for patients who shouldn't be discharged.
Right. Plus those patients may be especially interesting for understanding markers that we don't recognize explicitly now, I guess.
Yeah, and I think, let me see if I can go back a couple of slides. So this is kind of the aggregate, but this time to peak and time to wean, this duration was very, very variable. We've seen some patients that will do this very, very quickly and resolve very quickly, and we've seen some patients that will take 2-3 weeks to do this. And I think there are some questions, talking with you and Leslie, is what makes those different patients, what makes those patients different?
So then would the plan be to try to profile them as part of your stratification, I guess?
I think we're actually getting to sufficient numbers. I think we've historically now have had almost 60-ish patients who've ever gone to our ICU. I think that might be a little bit higher. I haven't looked at the numbers of the last 2 days. But we're actually, before we had binarized it into critical versus non-critical, but now we have multiple, while we have multiple subcourse, now we have a number of deaths, a number of intubations, a number of just critical care only. So that's definitely expanded.
Yeah. Okay.
Hey, Dan. Oh, sorry.
Questions?
Dan, can I say? Yeah, Dan Edmanuki. So thanks. That was it's amazing to see how quickly this has progressed into being a useful tool. And so thanks for that. I was just, wondering, I think in the initial iterations of this, in terms of the data you were feeding into the algorithms, just wondering what the latest thought is about oxygen saturation, when you could most use the oxygen saturation data, and then other indicators of coagulopathy, which seems to be, those two things seeming to be extremely interesting types of values.
That's a great question. So we actually presented, Peter and I presented to the intensivist a couple of weeks ago, and oxygen saturation came up. We had this discussion on it. The problem is that once you go to the ER, some of these patients are already on some nasal cannula, and so are their oxygen saturations kind of already biased since they're already on therapy. It's hard to know what the initial oxygen saturation number is. In terms of the sequential coagulopathy, we do collect I think the INR and the platelet and the fibrinogen. So we have some markers. So I think we have some of those.
This is, are we done there?
I think so.
I think this is tremendous accomplishment. congratulations on assembling this data in such a useful way. I wonder, I've been struck looking at the Orange County data, how stable the number of cases has been over the last 2 months in Orange County. And I wonder, but there does seem to have been a shift from the original outbreak, where it was largely in communities where there are many travelers, like my own in Newport Beach or Irvine, and now much more in the larger cities of Anaheim and Santa Ana. Have you seen a change in the nature of
Yes.
the patients that we've seen at UCI?
Yeah.
Severity or clinical course or anything over time?
Let me share another screen with you. This is from our actual data sheet. These aren't fully updated yet. I'm going to say it right now, but this is, gives you an approximation. We're currently, I think, in week 10 or 11, but you can see the dramatic shift that there are some groups that are really being disproportionately affected by COVID. And that's people who live in low-income neighborhoods, and it's not labeled here because I lost it when I updated it, but these are Hispanic Latinx. The majority of our patients that we've seen over the last couple of weeks, this is just, I haven't done stats on it, but I would say that the majority have come from Santa Ana, Anaheim, and Orange. And that's in our immediate capture net for UCI Health. These tend to be patients who are coming from disadvantaged communities. And I think that's one of the things we've seen. Just looking at our numbers, let me hide this because there's some PHI in this portion.
Dan, I think Sid might be asking about the progression of the disease. Sid, are you asking, does that correlate with this change in population, or you're not?
Yeah, I was wondering whether the change in population indicates something else about the severity of disease we're seeing at UCI.
I see. So I would say that the number of critical patients that we've had has definitely gone up. Whether or not what's driving that, we're still looking at. So Pierre and I are working with Bernadette and one of her statisticians, and we're looking at, are there any specific or unique drivers for why we're seeing this change? Because what you're saying is actually absolutely true. On week 8, we had about 45 patients. Week 9, we had 44 patients. Week 10, we had 43 patients. Week 11, we had 80 patients. So there was this sudden surge that we've just kind of seen, and it's kind of continued into now.
I do know part of that is the increased transfer rate from the other hospitals who haven't been able to manage the patients. So that some of that will be out of the county, and some of it might be in county, but some of it might be actually out of county.
Are they transferring to us because they're under resourced, Ed, or do they just don't have the clinical expertise to take care of that? Do you know?
I think it's a capacity issue at those hospitals. Okay. I think some of them are getting swamped.
It's kind of alarming.
Yeah.
But that, on the other hand, would probably distort any stratification you would do. So,
right. So. That's a confound.
I'm wondering, Ed, for those patients that are transferring to us, do you know who could be a liaison to maybe connect them with this tool? Because ideally, I think that's where you'd see the biggest benefit for hospitals that don't have these critical resources. If they get an early assessment, maybe they can transfer before they start tanking.
That is a really good point.
Yeah, I guess my first thought is to chat with Alpesh about that. Okay. Who the point? I mean, they're clearly tracking. I get the data every day on sort of transfers, at least the numbers of patients who are transferred, not COVID specific necessarily, but so there should be a way to do that, I think. But maybe Alpesh would be a good starting point to ask.
Okay, I want to respect everybody's time again, so thank you all.